Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning. Good morning. What's your problem? Well, doctor, I have intolerance to allergies, inhalant and environmental allergies. What's your age? 36. Okay, do you get any kind of reactions like an itchy rash, throat or tongue swelling, shortness of breath, vomiting, lightheadedness, and low blood pressure? Clinically, these symptoms show the presence of anaphylaxis. No, doctor. Or else, do you get itchy red welts called angioedema that develop on your skin? No, doctor. Are you taking any medication for allergies? No, doctor. May I know your past medical history? 6 months back, when I was under dialysis due to renal failure, I had an acute event of perioral swelling, etiology uncertain. The diagnosis results showed that the allergic reaction was due to Keflex that was used to treat a cellulitis dialysis shunt infection. What medications are you taking now? I am taking atenolol for controlling my blood pressure, sodium bicarbonate, Lovatsa, and Dialovite. I didn't have any other issues upon my treatment and discharge. That included corticosteroid therapy and antihistamine therapy and monitoring. What were the surgeries performed? Perm cath insertion 3 times and peritoneal dialysis. Are you allergic to any medications? Yes, heparin causes thrombocytopenia. Do you drink or smoke? No, doctor. May I know your family history of diseases? My family members have severe heart disease, carcinoma, and food allergies. Well, your test report shows your blood pressure is 128/78, pulse 70, temperature is 97.8, weight is 207 pounds, and height is 5 feet 7 inches. I suspect you have developed acute anaphylaxis. I would suggest you to go for a radioallergosorbent test, a blood test using radioimmunoassay test to investigate specific IgE antibodies to determine the substances the subject is allergic to. I shall recommend further treatment and medications upon the test results. If the test report shows any specific food or inhalant allergen that is found to be quite high on the sensitivity scale, I would likely recommend that you avoid the offending agent. Right now, I would recommend you to stop further usage of cephalosporin antibiotics, which may be the cause of your allergic reaction, and I would consider your case as an allergy. Being on atenolol, it would be very difficult to treat acute anaphylaxis. I am prescribing an EpiPen in the event of acute angioedema or allergic reaction or sensation of impeding allergic reaction, and you have to proceed directly to the emergency room for further evaluation and treatment recommendations after the administration of an EpiPen.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning. Good morning. Please be seated. May I know your problem? Well, doctor, I have multiple issues with my teeth due to severe dental disease. I have had many of my teeth removed. Now I have severe tooth pain. Both lower and upper teeth on my left side have been troubling me for the past 3 days. Well, what's your age? 29, doctor. What medications are you taking? I'm taking OxyContin and Vicodin for my knee pain. I need more pain medications because I do not want to use that medicine for my toothache. Are you allergic to any medicine? Yes, penicillin and codeine. Do you drink or smoke? I do not drink, but I do smoke regularly. Well, your test reports show temperature 97.9, blood pressure is 146/83, pulse is 74, respiration 16, oxygen saturation 98% on room air, and interpreted as normal. Mouth and oropharynx shows multiple denture and multiple dental caries. You have tenderness to tooth 12 as well as tooth 21. Your gums are normal. There is no erythema or swelling. There is no purulent or other discharge noted. The floor of your mouth is normal without any abscess, suggestion of Ludwig's syndrome. You have developed odontologia and multiple dental caries. Well, I am prescribing Dilaudid of 4 milligrams intramuscular, and I would suggest you go for a filling. In this treatment, the affected area of the teeth will be drilled, and the decayed substance will be removed, and the empty space will be packed with an appropriate dental filling material. Okay, doctor. Thank you.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Question 25. You hear a physician explaining the issues involved in treating lower back pain. Now read the question.
Lower back pain is one of the crucial issues in the medical field leading to disability, and it's growing alongside the aging population, which are more rapid in low-income and middle-income countries, where adequate resources to deal with this issue might not exist. Therefore, the impacts are probably extreme in such regions. Most of the lower back pain issues are unrelated to particular identifiable spinal abnormalities, and this announcement is an alert for action on the global issue of lower back pain. Typically, most of the clinical practice guidelines suggest similar approaches for the investigation and treatment of lower back pain. Their suggestions include the use of biopsychosocial strategy with initial non-pharmacological treatment, including the suggestion of self-management and resumption of exercises, normal activities, and psychological programs for those with continuous symptoms. Nevertheless, recommendations are mainly based on the trials exclusively from high-income countries, focusing mainly on treatments rather than its prevention. Therefore, there is a massive gap between evidence and the existing practice. Without the use of suggested first-line treatments and inappropriately high use of imaging, spinal injections, opioids, and surgery. Following similar strategies will never reduce back-related disability or its consequences in the longer run. The effective treatment will be those which align the evidence with practice, focus less on spinal abnormalities, and suggestions of activities including work participation. Although we have devised effective and promising solutions that require greater attention and intensive research to establish whether they are suitable for larger-scale implementation. These potential solutions include the redesign of clinical pathways, focused strategies to implement best practice, integrated health, and occupational interventions to reduce disability with prevention strategies.
Question 26. You hear a discussion about melasma and different types of melasma. Now read the question.
Hello, Doctor. What is melasma, and what are the types of melasma?
Well, melasma is a common patchy brown, tan or blue-grey facial skin discoloration, normally seen in women during their reproductive period. It typically appears on the upper lips, upper cheeks, forehead and chin of women of 20 to 50 years of age. There are 4 types of pigmentation patterns are diagnosed in melasma: epidermal, dermal, mixed, and an unnamed type found in dark-complexioned individuals. The epidermal type is characterized by the presence of excess melanin in the superficial layers of skin. Dermal melasma is defined by the presence of melanophages throughout the dermis. The mixed type includes both the dermal and epidermal type. In the 4th type, excess melanocytes are present in the skin of dark-skinned individuals.
Question 27. You hear a discussion between 2 doctors about VX and its effects. Now read the question.
Hello, doctor. What is VX and how is it obtained? VX is a man-made chemical warfare agent classified as a nerve agent, which are the most toxic and rapidly acting of the known chemical warfare agents, which are similar to pesticides called organophosphates. Symptoms will start appearing within a few seconds of exposure to the vapor form of VX, while the appearance of symptoms may take from a few minutes to 18 hours of exposure to liquid form of VX. Compared with a nerve agent called sarin, VX is much more toxic by entry through the skin and much more toxic by inhalation. Since VX is the least volatile nerve agent with the slowest evaporation level from liquid to vapor, it can be a long-term threat as well as a short-term threat.
Question 28. You hear a nurse in the emergency department discussing the care of a patient with a doctor. Now read the question.
So, who have we got here?
This is Adam King. He was brought in with a dislocated shoulder. He has Marfan syndrome, so we've seen him before with this. Last time he was here, the shoulder popped back in while we were putting his arm in a sling, and he was able to put it back in himself just by relaxing his muscles, but he's in quite a bit of pain right now, so he's having trouble calming down and getting those muscles relaxed.
Right, I see. So, do you want to start with some nitrous and some pain relief?
Yes, I think that's best, just until he calms down.
Question 29. You hear a discussion between a doctor and nurse about the cause of glioma. Now read the question.
Hello, doctor. What is glioma, and what is the exact cause of glioma?
Well, the exact cause of glioma is yet to be defined, although some hereditary disorders are known to increase the chances of developing these tumours. Examples of glioma include tuberous sclerosis and neurofibromatosis. Depending on the specific type of cells involved, gliomas are categorized into different types. Ependymoma tumor arises from the ependymal cells that are found in the brain ventricles and spinal cord. Oligodendroglioma involves the cells called oligodendrocytes that provide insulation in the form of myelin. Astrocytoma tumor involves the astrocytes, which are the cells that transport nutrients and providing structural support to neurons. Mixed gliomas are the tumors that contain a combination of cell types, such as an oligoastrocytoma, for instance.
Question 30. You hear a doctor explaining to his nurse about functional gastrointestinal disorders. Now read the question.
Hello, doctor. Can you explain to me about functional gastrointestinal disorders in patients?
Well, functional gastrointestinal disorders is common in my daily clinical practice. This is characterized by difficulties in motility patterns and visceral hypersensitivity. If the patient is bloated and gassy, you should get them treated before the condition progresses. Bloating after meals, loose stool, constipation and gas are the minor symptoms of functional gastrointestinal disorder, while acid reflux, foul-smelling gas and abdominal distension are major symptoms of the disease. The symptoms such as foul-smelling sticky stool, hematochezia and the sense of urgency to defecate are the severe symptoms of the disease.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the monologue of a physician, giving a lecture on the different types of non-Hodgkin's lymphoma. You now have 90 seconds to read questions 31 to 36.
The 2 main categories of lymphoma are Hodgkin lymphoma and non-Hodgkin lymphoma. Non-Hodgkin lymphoma is a large group of diseases with different symptoms, treatments, and outcomes. The appropriate name of the type of non-Hodgkin lymphoma may include a number of descriptive terms that can be difficult to understand. Lymphomas arise from lymphocytes, a type of white blood cell, which are of 2 types, T cells and B cells. Both help in killing infectious agents, however, in slightly different ways. Based on the type of lymphocyte turned into the cancer cell, the patients may have a T cell or a B cell lymphoma. B cell non-Hodgkin lymphoma is the more common type. There are many different types of B cell and T cell lymphomas, each behaving in a different way. Pathologists performing biopsy of the tumor define the cancers in terms of grade. High-grade lymphoma cells look quite different from normal cells. They tend to grow aggressively. Low-grade lymphomas have cells that look much more similar to normal cells and multiply gradually. Intermediate-grade lymphomas fall somewhere in the middle. The behavior of these types is also described as indolent and aggressive. What the pathologist describes as a high-grade or intermediate-grade lymphoma usually grows fast in the body, so these 2 types are considered aggressive non-Hodgkin lymphoma. Surprisingly, aggressive non-Hodgkin lymphoma often responds better to treatment, and many people with aggressive non-Hodgkin lymphoma are cured if they are diagnosed early. The most common kind of aggressive lymphoma is diffuse large B-cell lymphoma. On the other hand, low-grade non-Hodgkin lymphoma grows gradually, and these lymphomas are therefore called indolent non-Hodgkin lymphoma. This group of non-Hodgkin lymphoma doesn't give rise to too many symptoms, but they are also long-standing and are less likely to be cured. The most common kind of indolent lymphoma is follicular lymphoma. At times, indolent lymphomas can transform into more aggressive. The majority of lymphomas are nodal lymphomas. That means they originate in the lymph nodes. However, it is possible for lymphomas to arise from anywhere else. When the lymphoma is mainly present in nodes, it is called nodal disease. Occasionally, most of the lymphoma may be in an organ that is not a part of the lymph system, such as the skin, the stomach, or the brain. In such condition, the lymphoma is referred to as extranodal. Therefore, nodal and extranodal refer to the primary site of the disease. A lymphoma can develop in a lymph node and then involve other parts at a later stage. However, in such a case, it is still considered a nodal lymphoma, but is said to have extranodal involvement. In follicular lymphoma, the cancer cells arrange themselves in spherical clusters called follicles. In diffuse non-Hodgkin lymphoma, the cells are spread around without any clustering. Most of the time, low-grade non-Hodgkin lymphoma looks follicular, An intermediate or high-grade non-Hodgkin lymphoma looks diffuse in biopsy. Non-Hodgkin lymphomas are also described as common or rarer based on the statistics of the new cases every year.
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a physiotherapist called Chris Maloney giving a presentation about treating a high jumper with a knee injury. You now have 90 seconds to read questions 37 to 42.
Hello, I'm Chris Maloney, a physiotherapist specialising in sports injuries, and I'd like to present a case study to give you an idea of the sort of work I do. It features a very successful high jumper in her mid-20s who was referred to me with severe pain in her right knee, and that's the leg she takes off from when she jumps. What's more, when she stepped up her training in preparation for a big competition, the pain worsened, and she'd been forced to pull out of the event. After that, she'd taken several months off training to rest and get treatment from various therapists. To her dismay, however, not only did the pain continue, it actually got worse, meaning she was unable to do any strength training, let alone jump-specific work. By the time I saw her, she was on the verge of giving up, having lost virtually all belief in her ability. My initial assessment quickly confirmed patellar tendinitis in the affected knee, accompanied by some swelling and significant tenderness over the lower part of the kneecap. This wasn't difficult to diagnose. I also noted that she was slightly overweight for her height and had rather flat feet, but that's not so unusual in high jumpers. Further assessment revealed that the gluteal muscles connecting the hips and thighs were considerably less sturdy than you'd expect in an athlete of this calibre, and both the lateral retinaculum connecting the patella to the femur and the iliotibial band, the ligament running down the outside of the thigh, were tight and tender. As a first stage, I was keen to show I could help by relieving some of the pain. So I worked at loosening her lateral retinaculum to see how much of the tendon pain was due to inflammation and how much came from restriction of normal patellar movement. This manipulation and massage instantly cleared the pain she'd felt while doing a single leg dip exercise, where you stand on one leg and bend the knee. This indicated that her tendon pain was most likely due to patellofemoral joint dysfunction, caused by muscle imbalance and poor biomechanics, and not by an active inflammatory process or partial tear in her patellar tendon. So an MRI scan wasn't needed. The treatment continued along similar lines for some weeks, with loosening of the lateral retinaculum and deep tissue massage of the iliotibial band and other muscles. One option at this point was something called taping. This is a way of reducing pain so that athletes can continue with strength exercises. But it seemed clear from early on that we shouldn't put taping on this patient's patella and tendon until she started jumping again. She was getting pain relief and progress simply from the manual techniques, and taping might have led to problems later on. Athletes often become dependent on tape and other accessories. In other words, instead of aiming for 100% muscle strength and joint position control, they settle for 80% plus artificial support. The patient also had a specially designed program of gym activities. Although she needed to restore power to those muscles affected by inflammation and tenderness, the priority was to get her posture and alignment right. She started by doing double leg squats with her back to a wall in front of a mirror so that she could see whether her feet were arched and if her knees were over her feet. She also did squats while squeezing a ball between her knees. There was light leg press work, followed by single leg stance work, first static, then on wobble boards, and with elastic resistance. She progressed to moving on and off steps, sometimes holding weights, all the time paying close attention to positioning and muscle and joint alignment. The next stage was to liaise with the patient's coach. She began running, jogging for stamina, and then sprint sessions. Work on power was stepped up gradually and included some weightlifting. After some analysis, we also decided to modify her run-up to the high jump bar. By beginning from a wider position and running in with much less of a curve, there was much less of an impact on the ankle, knees and hip, especially in her right jumping leg. Interestingly, the patient reported that remodelling the run-up felt fresh and motivating and helped to reinforce the sense she had of being a reborn athlete. Once the rehabilitation process was complete, she was able to compete without pain and free of any reliance on taping or knee strapping. So, before I go on...
That is the end of Part C. You now have 2 minutes to check your answers.